We're going to go ahead and get started. This workshop is Protect Yourself and Your Family with Dr. Charles Bentz. Dr. Bentz is a general internist in private practice in the Portland area. He's been working for over 25 years, plus, with caring for patients nearing the end of life. He's a professor and medical director for the Pacific University School of Physician Assistant Studies. He is a fellow with the American College of Physicians and is also associate professor of medicine in the Division of General Internal Medicine and Geriatrics at OHSU. He is a great speaker, I have to add, and welcome, Dr. Bentz.
I usually don't need a microphone, so if you can't hear me, raise your hand. I might call on you, so be careful if you raise your hand. You might get asked a question when we're done. All right, there's a couple handouts in the back, and they look similar, but they're different. So hopefully there's still a pile of them. If you don't, you'll have to share. So we're going to talk about advanced care planning. I think in the program it said protect yourself and your family, protect your family. I thought this was a firearms thing, maybe not. No, it's not. This isn't about concealed carry. This is about something else. Okay, just want to make that clear. So, what am I doing here? I think we want to talk about some principles of what we're talking about here. When you get close to the end of life, there's some things we have to understand about what happens and what the risks are. We're going to go over that. We're going to talk about the advanced directive, and we're going to talk about the POLST, the Physician Order for Life-Sustaining Treatment, and then I'll have a few conclusions that I have after doing this for a while, and then we'll open a door for questions. Hopefully we'll be done before the next session starts. The next session starts around 4:10, so we got to be done by 4. I can stay after if people really want to complain about what I said. So here's some principles. And they're self-evident, maybe, but maybe not. It's worth actually talking about them. The first is that we all die. There's no one here. What's the mortality rate in Oregon? Well, it's 100%. Okay? So this is what we do. Also, killing people is not good. Intentional killing is never good. All right? Innocent human beings. Dignity is inherent in all of us. All of us have dignity. So when someone says, you know, I want quality of life or I want dignity, we all have that. Dignity and suffering are not exclusive of one another. You can have suffering and still have dignity. We need to protect using ordinary means. We're going to talk about what that means. What is ordinary? What is extraordinary? We'll talk about that. And I think it's very important to say, well, how do we know? Well, what's the benefit and what's the burden of the treatment? And that's actually what we'll get into. And we certainly have to respect each other. And we have to respect the everybody's autonomy, everybody's ability to make their own choices and live their own lives. We have to respect that. And that's something that I think is lacking in today's civil discourse. So what is autonomy? What is this thing? We all hear about it. But we need to respect someone's right to make a choice, even if it's not the choice we would make. And it assumes that person has the ability to act rationally. And how many of you have had teenagers? So sometimes there has to be some that overrules that autonomy until they get it right, until their judgment sort of catches up with their biological age. But you have to assume someone's acting rationally, and that no one's coercing them, and that it has to be voluntary. So those are all things we have to make sure that we're doing. And it involves refraining from interfering with someone else's choices and not having our way over someone else's, but also it's allowing other people to make that choice and to help them with that. And these are difficult issues. But it's what we do it's actually called informed consent. If you got to make choices about what to do, say you're faced with a critical illness or a long illness, what do we do? Do we do this? Do we do medicines? Do we do maybe a cancer? Do we do chemotherapy? What do we do? It's called informed consent. It's like we need to inform you of all the choices, and then you can give consent to what you want to do. And this is just what we take for granted, but you just have to stop and let's really explore this. And it's okay to explore the rationality of someone else's decisions. This is important. We also have to understand the concept, and so that's just, we need to allow people to choose. We're all free. We all have freedom to choose. Some people make bad choices. Some people make good choices. But the one thing we have to understand is that we have to respect each other and someone's right to choose. And that's what we have to do, and especially when we're dealing with end-of-life issues. Now, I think it's also helpful to talk about dignity. So what is dignity and the so-called death with dignity? Well, when you think about dignity, what is it? I mean, I think one of my favorite pictures to me of dignity is Martin Luther King. Where is he right now in that picture? You guys remember? Birmingham, right? What happened? He was told, don't march. You're going to go to jail. And he's like, I'm going to march. We need civil rights. Need them now. Went to the president. The president says, no, we're not going to have civil rights legislation. We're not quite ready for that. He said, well, the heck with that. So he's down there leading the march. He gets put in jail. And a black man in jail in the 60s is not a place that you want to be. It's not a place of dignity. Okay? But look at him. That's the most dignified picture of a man I've ever seen. He knows who he is. He knows where he's going. He knows what he's doing. And it's all about doing the right thing for the right reason at the right time. And that's dignity. So that's what you have to take a step back from the circumstance. And I think about the second picture. I mean, let's look at this old frail gentleman in bed, and you might just look at him and he's in a hospital bed and he kind of looks pretty miserable there. And we've all seen that. Maybe that's one of our relatives. But all of a sudden you see, well, look at the little baby with them. That changes. It didn't change. Nothing changed other than our perception. Who he is, what he's about, what he means to the family. What kind of life he's led. There's just dignity just in who he is, where he's going, what he's about. The whole setting is dignity. And so you have to take your eyes off the superficial and you have to get to the substance. Okay? And that's of what it really is, the meaning of it. And I think that's when we talk about dignity, there's dignity in each one of us. And we kind of maybe break it into two things. Attributed dignity, which is the dignity that we see, it's the visible, it's what we attribute. When you see someone who seems dignified, it's about their bearing, their manner, their abilities. It's on the surface. It fluctuates depending upon the circumstance. And you can see someone maybe older, maybe not quite so dignified, maybe someone who is ill, maybe they're incontinent, maybe they're in a hospice, maybe they're just not doing well, maybe they're on the street. You can say, oh, that's not dignified, I don't want to live like that. But you have to understand, we're talking about that's just surface dignity. The true dignity is the inherent value of a human being. Wherever they are, regardless of the circumstances, their assets, regardless of whether a person feels dignified themselves. And it extends from conception to natural death. That's the arc we're talking about. All right. So the quality of life, you hear, well, I want to quote quality of life. It's a dangerous concept. It's very dangerous. And if we use that as our only criteria for dignity, well, everybody has different values, different qualities. So what's quality of you might not be quality for someone else. And who determines it? And how if someone has poor quality of life, how do they stand up for themselves? This is something we all have to understand. And as your life changes, and many of you may be seen this in a relative who's sort of maybe have their health drifting down and their abilities drifting down, maybe their cognitive faculties are drifting down. When do you make that judgment on someone, and how can you make that judgment? And then when they become lower in this so-called superficial sort of attributed dignity, they become very vulnerable, and they can be some of the most vulnerable. And I think about some of the patients. I was just in the nursing home yesterday teaching some PA students yesterday afternoon. And the people who are there who are alone and vulnerable, they're unbefriended, they don't have anybody. They're ripe for being abused. It's a dangerous place to be, is alone and old and unaffiliated and unbefriended. So I want to talk about a case that actually here in Oregon, it's a pretty important case. Everybody should probably know about it. It's the case of Nora Harris. So Nora signed an advance directive. We'll talk about that, saying, don't, she filled it out, and she didn't want any, heroics. And she developed dementia and was in long-term care. And her husband noticed, she's there and she's being spoon-fed, and she actually is pretty happy, and when you give her a spoonful of food, she enjoys it, and she eats it, and she smiles, and this is what's happening. But her husband says, this is not dignified, and we need to stop her spoon feeding. We need to stop this feeding. And at the time, they said, well, we can't do that. It's against the law. You can't just stop feeding someone. And so he took it to the court, and actually, it actually failed. And but a year later, she died of natural causes. She was, elderly woman with dementia. And the question is, well, was feeding her ordinary? Was that ordinary care? Was that extraordinary? And that's where this kind of came up, and there was a law passed here this last 2 years ago that actually changed a lot of definitions in Oregon, and this was the case that brought it about. And what happened was, now we think differently about what ordinary care is because of Nora. And so let's talk about ordinary and extraordinary care. Let's just think about it. So what is ordinary? Well, we think about ordinary, or something that's proportioned, something that's appropriate, ordinary, in the judgment of the patient. It means that they offer reasonable hope of benefits. This is something that's going to benefit you in some way. And it's not really burdensome. It's not really horrible. It's not going to be really terrible to do. It's going to be of benefit and of low burden. And this is ordinary. Now, what's extraordinary? Well, something that's maybe not appropriate or disproportionate. And are those, again, in the judgment, and we're taking mostly about from the patient. They don't offer any real benefit, and or they entail a burden that's really beyond what you would expect. And so you might say, well, ordinary, extraordinary, you can't really tell about what's ordinary or extraordinary until you get some idea of what's beneficial and what's burdensome. So that's what we do. We have to go, okay, is it ordinary care or extraordinary? Well, let's figure out, well, what's the benefit in this case, and what's the burden in this case? So how do we do ordinary? Well, that would be something that's helpful. It's beneficial. And it's what you would do normally. And extraordinary, well, maybe that's something that we wouldn't do normally. It might be painful, or it's really, really causing a big burden. So how do we sort of sort through this? Well, it turns out that there's not a book that says this is ordinary under every circumstance, this is extraordinary. This is beneficial in every circumstance, this is burdensome in every. It really depends. What's beneficial and burdensome here in Portland metro area is probably different than what it is in Ethiopia, or it is in Bangladesh, or rural Oregon. Maybe there's some differences that we have here that it's really hard out in the country where there isn't anybody. There isn't all the supports that you can get. So I think it's important to understand that determination of whether something's ordinary or extraordinary or proportional or disproportional is based on the things that you're doing, not the consequences. And so, like, the patient is never the burden, all right? You have to, and it's sort of like when we're hearing about assisted suicide, some Dr. Toffler spoke about earlier, you don't stop the suffering by killing the patient, okay? That's not, let's just stop suffering by just killing people. That's not what we do. We can be really, really aggressive in our approach to palliative care. So aggressive, in fact, that you might even hasten their death by this. You talk about people say, oh, I don't want to go to the, I was talking to someone earlier today that says, oh, don't go to the hospital. They'll just give you morphine there and you'll die. Well, that might be true, but it might be appropriate. People are suffering, and at the end of life, to withhold morphine is to torture them. It would be inappropriate. If someone's suffering into life, man, you give a bunch of morphine. And they're no longer suffering. Now, they might die sooner, but that's ordinary and normal care, and to withhold that would be immoral. Not only malpractice, but it would be wrong. So sometimes you have to give a lot of pain medicine to really help someone alleviate suffering in their life. It happens. But you don't just say, oh, this person's suffering, let's just kill them and put them out of their misery. So you could be looking at something from the outside. So I'm standing back here and I see suffering patient, doctor comes in, she gives a really high dose of morphine, patient dies. Is it right or wrong? Was it bad or good? You can't tell. Was this patient suffering greatly and the doctor came in and she basically gives just the right amount to stop the pain and the patient dies? Well, that's good care. Or you got, patient suffering, doctor comes in and says, oh man, this suffering, I can't stand it, it's bothering me. I'm just going to slam a bunch of morphine, kill the patient so I quit suffering. But from 30 feet back, do you know which happened? Can you tell which happened? Not unless you're right there at the bedside. And sometimes you don't know. So what does that mean? It means you want to get to know your doctor. A little bit. That'd be nice. We gotta go back there. Dr. Toffler's doing patients yet? Not yet. In your new practice. I can't wait. The thing about it is that the patient's not the burden. Like, well, this is so burdensome because the patient's going to be alive forever now, and that's a burden to me. That's not what we're talking about. We're talking about the burden of the treatment, not the burden of the patient. Patient's never a burden. So we're going to talk about advanced directive and POLST today, and this is a kind of a summary table that I'll go over again at the end of the lecture. So don't worry about getting all this right now because we're going to go over some of these things. But in reality, the advanced directive is something that you fill out yourself, and it's for healthy people. Like everybody in this room should have an advanced directive. Everybody. The POLST, on the other hand, is for people who are sick and are maybe close to death. Now, maybe there's someone in this room who needs a POLST. I don't know. We can talk later. But we'll talk about that. But there's two things, and I want to start with advanced directives. So how do we protect ourselves is, first of all, understanding all of this, and secondly, having someone who can help you and be at your side. And the history of advanced directive is that, people were kept alive, or, maybe they're allowed to die, we didn't really know, and people's wishes weren't followed. So back in the 70s, they said, we got to have, people get hooked up to machines forever and ever, and I don't want to be that person. I don't want to be hooked up forever. And so we need to be able to say, please don't hook me up to a machine. Don't, pull the plug. Well, just don't plug me in the first place, okay? And so the first statute was in the mid-70s, and Oregon was an early adopter. And basically in 1990, the Congress said everybody goes to the hospital needs to be handed an advanced directive. So since the 90s, if you've been in the hospital and you leave and there's a big pile of paperwork that you're given on your way out, there's an advanced directive in there. So everybody's been getting advanced directives for several decades now. So what is it? It has two functions. The first is to identify a healthcare representative, a healthcare advocate, or a power of attorney for healthcare. And this is a surrogate decision maker, someone who can legally make decisions for you when you're not able to do so. And it's a proxy. In Oregon, it's called a healthcare representative. And the second part is the living will. It's sort of like, okay, if I can't speak for myself, here's the things I want done or don't want done. It's kind of like that. Now, what is a will? Well, a will, you guys know, if you die, who gets the car, who gets the house, who gets the 401k. A will says where things go. Now, when you're, I'm not available. I'm in the middle of a talk, so you can just tell her to call back. So someone who's alive, you can say, hey man, here's my car, you give away your house. If you're alive, you're under your own, under our own power, and when you're dead, you have a will that says where everything happens. But what happens if you're alive but not able to speak? You need something that says, well, who directs care at that time? That's where the advanced directive is. That's what it's for, okay? And it can actually have all sorts of information about it, and in it that can talk about whether you want, what kind of interventions you want, maybe to keep you alive or not, or whether or not there's other things. Now, the Oregon Advanced Directive has changed. The Advanced Directive, and we're going to go over the handout, is that in 2018, there was a House bill that was passed that says, okay, we're going to make some changes to the existing Advanced Directive, and they improved it. They actually made a place now where you can put someone's email. It was nice. It allows for 2 alternate healthcare representatives. The old one, you could only have 1. But it changed some of the definitions in that your healthcare provider could include your facility where you are. They could actually be, make decisions for you. And that tube feeding, when it says tube feeding, it actually means anything, including any kind of feeding that's, not you feeding yourself. And so spoon feeding, anything, it's called artificial. If you can't actually put the spoon in your mouth, swallow yourself from the plate to the mouth, that's called artificial feeding. So that's considered artificial now. So it's just changed some definitions. Some people were kind of like, oh, no big deal. We'll talk about what that might mean, though. And they've adopted a plan to have a statewide appointed commission that will then update this every 4 years. So we will have a new advanced directive every 4 years with more and more sort of changes to it. So this is something that has to be on everybody's radar screen now, so which is an important thing. So I'm going to go over the advanced directive. Now you have 2 white handouts. One of them says Advanced Directive, State of Oregon, on the top. I'd like everybody to grab this. It says Advanced Directive, State of Oregon. Now if you don't have one, you can share. Someone next to you has one. Be nice. Share. So there's 2 of them. The other one says Form for Appointing Healthcare Directive. We'll do that later. But this one says Advanced Directive, parentheses, State of Oregon, in parentheses. Does everybody have it? If you don't have one, share. There's a couple of handouts at the back. If you don't have this, it's online. You can download it. It's available. It's free. You can find this. All you have to put in your Google search is Advanced Directive, parentheses, State of Oregon, in parentheses. You put that in, you'll come up with a PDF. All right. So what is it? Well, the first section is about me. You put your own information in. Second section is you put your healthcare representative. The first is your primary, the person who you would appoint. Now, in Oregon, if you're married, your spouse automatically is a healthcare representative. So you don't have one of these. Your spouse automatically is by law, legal spouse is a healthcare representative. Now, if you don't want your spouse to be your healthcare representative, and that happens sometimes, if your spouse has different values, seriously, or you're kind of worried maybe about, the arsenic and lace that might be happening. The older people got that reference. That's good. I like it. I teach PA students, and that would go, shh. They wouldn't even understand that. They would not get that at all. All right. So the second part of it goes on to the second page, and there's 2 alternates, alternate 1, alternate 2. We're still in section 2. Section 3, instructions. Okay, this is what you could put in. This is where you could put in some of those instructions that you might have. And 4, directions. This is something, again, where you could actually, they give you a whole entire, you know, if you go to page 4, it's actually pages 3 and 4. It's section 4, pages 3 and 4. They give you 4 scenarios, and they're poorly written. They're horribly written, as a matter of fact. And they give you these horrible sort of options to check that actually, given the recent House bill, can mean anything. And so this is a real dangerous part of the form, okay? This is the part of the form like where you're swimming with the sharks or the crocodiles. I mean, anything can come up and bite you here. So this is, because you really don't know, and you can almost read anything into them. They're so non-specific. And I really like on page, let's just look at, you know, section 4 on page 4, and it's actually option number 4. Okay? So it's page 4, section 4, number 4. So there's 4 4s, so you guys will probably be able to find this. Well, let's read it. What does it say? Extraordinary suffering. If you're suffering extraordinarily, do you want us to pull the plug? Now, what does it mean, though? What is extraordinary suffering? I mean, the Packers lost. I can't tell you how horrible that feeling is right now. You know, they don't have Brett, okay, I know. But Aaron Rodgers, he's so awesome, and they lost, and they weren't even in the friggin' playoffs. I mean, there's something wrong with the world, and I just cannot go on. Now, I lived in Green Bay for a while, or I lived in Milwaukee, Wisconsin for a while, and I know people like that. I was acting. That was my roommate. I was sort of channeling him. Have anybody ever lived in Wisconsin, Green Bay, anybody? So you know what I'm talking about. They're crazy. They're insane. But you know how I feel. You probably were like, yes, life isn't worth it. Sorry. I just want to I do it facetiously to tell you, these things, these forms can really be used for anything. So we have to tread lightly here, but I'm going to tell you how to do it. Let's go through the rest of the form. Page 5, you know, or section 5, excuse me, your signature. So you sign it, and then on, you know, section 6, you can do some witnesses. You can either do notary or you can have witnesses. The witnesses can be anybody. The mailman can be the witness. The mail person, I suppose, can be the witness. You know, you could have anybody. And then the last part, it'd be rude to have an advance directive and appoint someone without them agreeing to it. That'd really be rude. So the last page is called my politeness page. Okay, yes, you should probably have someone agree to be your healthcare representative. Okay, that's the advance directive. Pretty straightforward. Now, what's the problem? The problem is that middle section, okay? Section 3 and section 4, they're kind of nebulous. So there's another way to do it. But before we get to that, let's talk about how do you pick a healthcare representative? Because that's really the most important thing. I tell people, leave sections, you know, 3 and 4 blank or put a big X on them, because you should just pick someone who has your values and can advocate for you, and don't put out any of the specifics, because they can read into them whatever they want. Just don't put anything down. Pick someone. So who are you gonna pick? This is probably the biggest decision you'll ever make. Most important decision you'll ever make. And some people, I take care of people in nursing who don't have anybody. And one of probably the most important things you could do is go to the nursing home and befriend someone and become that person. I recently took care of a retired gentleman who had nobody, and he was becoming demented, and he wasn't pleasant. But there was a gal who for some reason just came by, latched onto him, and she was his lifesaver. And she stuck with him for the next 4 years, and we just had his funeral. And she was, you know, finally, I would talk with her a lot, because she's the one who'd bring him to his appointments. And she was the one who helped out, and she was just someone who just knew that this old, elderly man who he was born in a foreign country, didn't have any relatives here, was marginalized. He was in his 90s, so anybody he did know was dead. And so he just had nobody except for a person. And I think that she's going to be in heaven for this, because this was just she's the most amazing person I have met in my last decade, because she just did it because it was right. And I had a front row seat to sainthood. It's pretty cool, okay? I saw it, and it was impressive. And there are people in this room who could do the same thing, okay? Because this is what you need to do. But having gone off on that tangent, choosing a health representative for yourself, because people here, who are they? And this is something that we need to know. Tom, where are you? This is what we're talking about, okay? This is really important. So let's look at this. Someone you know and respect, someone you trust, someone you can communicate with in an ongoing fashion. Because things change over time, and this is someone who you want to know, who can make sound decisions. Someone who can make a decision. Do you know anybody who can't make a decision? I actually know several people in my life like that. Like, good Lord, just make a decision. So who understands what your ethics are, what your values are, and who can commit to you and you commit to them to communicate, and who can apply practical wisdom. I saw that line. When you're going into the sanctuary, do you see that thing says practical love? On the way in, when you're going over to the sanctuary for the final talk, they got a little thing here in this church. It says practical love. It's right on the thing as you go in. I said, man, that's awesome. I mean, I want to love, but I want to do practical love, something that actually makes sense and helps someone. What a great term. I like it. That's why it's nice having, I love this place. This is a nice place to be, don't you agree? Nice place to have a conference. Anyway, so practical wisdom, someone who lives nearby is preferable, but with Skype and with Zoom and with a lot of the technologies that we have, you can actually have people who aren't close in case you have to connect with them. I don't think it's an absolute. And it's not an honorary position. Don't give it to the oldest. That's just stupid. The oldest sometimes isn't the one. You want the baby. They're the one who loves you. Because you got to spend the most time with them, and you weren't as disciplined with them, and they actually are the ones that's your favorite. So you might not want the oldest. And don't give it to the nurse. Don't give it to the doctor. Just give it to someone who would do what you would want to do, who would protect you, or would say, she suffered enough, let's just stop. We can do what keeps her comfortable, but we don't need to fight this anymore. She's a fighter, but good Lord. This is World War III and then IV. Now we're in World War V. Let's stop. That's probably the most important thing, is to have someone who knows when to say stop. Okay, so this advanced directive, number one thing, important, get a healthcare representative. And I don't know if you have one. Maybe you find one. Maybe it's time to go and start talking with people. If you're the person who's living in the shack up in the mountains and you sort of wander down and are in this conference now, get a friend. It'd be nice. Don't blow us up. All right, another option. Now this is handout number 2, is basically where it says, form for appointing healthcare representative and alternate healthcare representative, parentheses, state of Oregon in parentheses. So this is the form that comes out by the state that actually all it is it's just the appointment of the healthcare representative and the witnesses. It doesn't have all of the advanced, all of the will, all of the, instructions for life. And so this is actually something that I think is actually probably what I'm going to fill out, because I've been doing doctrine for 30 years. I can't figure this thing out. I can't figure out the form with all these options. They're meaningless, especially now since all the terms have been, completely changed. So this is another option, and they're both available. They're both official forms. So you could say, well, I either won't put anything on it, or I'll do this other form which doesn't have it. So you've got 2 options here. Now, I'm going to go to a third option. Okay? There is a third option. And this is what Oregon Right to Life is in, and I think it's awesome. So you've seen this. It's actually going to be, I understand the website isn't live yet, but it's going to be close. But what they've done at ORLTF, right? TLF, LTF, what, or TL. All right. What they've done is they put together an advanced directive that's the same form, but what they've done is they have about 6 or 8 pages here. Looks like 7. They've got 7 pages of preamble. 7 pages that goes over all the stuff I just said, except probably with proper grammar. It's probably been spell checked, I'll bet. And so it's a good thing. And then it starts on page 8, well, actually, is the advanced directive. They have our advanced directive. And what they've done under section 3, if you go back here, oops. If you go to section 3 where you can give the directions, they've actually put in a whole bunch of really positive things. This is what we want. It's my presumptions for life. You could actually write up something. This is what I want, this is what I don't want, this is what I believe, this is what I don't believe, and you can actually put instructions in there. And that's what they've done here. And it's actually really well written, it's really well done. And it actually goes on for a page and a half, almost 2 pages. Okay? And then they have the rest of the advanced directive. So you can do one of 3 things when it comes to this dangerous section 3. You got 3 options for 3. 3 for 3. How's that? All right? The first thing is you could just put a big X through it or ignore it and just put it in without signing it at all. The second thing you could do is you could get a form, the second form, which actually doesn't even include it. And third, you could do something like what Oregon Right to Life has done, is actually you could actually have a well thought out, nice sort of section of what your values are and put that in. Okay? Or I suppose you could fill it out and, you know, hope for the best, but I wouldn't recommend that. So it's 3 good options. So what do you want to do? What's the right thing to do? I don't know. I tend to want to, I'm a minimalist. Now, my son's a minimalist. He lives in a tiny house. And he has like 1 coffee cup. And they live literally in like 200 square feet. I mean, they got a solar, they got a composting toilet. I mean, they're hardcore. They're like tiny house living. I appreciate it. I actually respect it. Low carbon footprint. There's a whole ethic that goes behind it. And the ethic is, we're not going to do a bunch. We're not going to own a bunch. We're not going to have a bunch. And he would probably do this too. Okay? 3 pages, it's done. And so that's advanced directive. I think that's important. All right. The take-home points. A healthcare representative, pretty important. Get a good one. Communicate with them. This isn't like appoint them and forget about it. This is someone who you have a relationship, hopefully. Communicate. Continue to communicate. And those check boxes in section 3 and 4, don't go near them. They're poison. They're bad for you. They are meaningless, and actually they can be harmful. So stay away. You got 3 options for that. Number 1, just stay away. Number 2, get a form that doesn't include them. Or 3, put something in that you believe in. I think they're all okay. I think all those are good options. All right. Now we're going to talk about something else, the POLST. So POLST is different. POLST is not an advanced directive. POLST is something you do not need to have. What is the POLST? The old one is this purple, the pink one. The new one, I guess, they didn't want to waste pink, so they put it just in the margins. But this is what it is. And what is POLST? POLST is a physician order for life-sustaining treatment. That's what it is. It's an order. Has to be signed by provider. Now, they were first used in the 90s by OHSU. OHSU was one of the first places in the country that actually had this. It was developed. And it consolidated a couple things, the do not resuscitate order, into something that would travel with the patient. Because oftentimes, and here, this is bad, so it's 1985, you're on hospice, you're basically in the throes of expiring and moving on to glory, you know, the celestial stairway. You're about ready to head up, and because they called 911 because your family was too freaked out because you were really, they couldn't handle it, so they called 911. Paramedics come by, they have to resuscitate you. They don't have any option. And so here's someone who's dying, who they knew was going to die and expected to die, but then because they were suffering, they called 911. 911 had to resuscitate them and brought them to the hospital. Next thing you know, they're in the hospital, in the ICU, on a machine. And everybody comes in and says, what the blankety blank is going on here? Don't you understand? And there was no way to do it because you call a paramedic, they can't make that choice. So there's a real problem with end-of-life care back in the 80s. So they said, we need to have that DNR, because there's people who you don't want to resuscitate. There are people who are dying you do not want to resuscitate. You don't. So we need to have this, maybe a portable DNR order that goes with them. And let's call it a physician order for life-sustaining treatment. And let's add a few other things in there, since we have it, since we're going to it. So let's add in a couple of other things. Maybe should we be doing tube feedings? Maybe we should do some of these other things. And they came up with it. And it was intended to be something that would follow someone around who you really didn't want to do anything for. And it's different than the advanced directive. The advanced directive is basically written by, Healthy, what do you want done in these cases, and who should do what, and how do you do that? But you need some time. This is about what's going to happen in the future, what the paramedics need, and they need something right now. I need an order to follow. And so it was initially intended to remedy some of these limitations of the advanced directive. And so it is a medical order. So it's not a physician's suggestion for life-sustaining treatment. It's actually an order. And my sister's a nurse. And that's one of my favorite things when I worked with her. I was in the ER. She was the nurse. I was the doctor for the evening. She's a bossy older sister. And I said, this is an order. I wrote an order. And I said, you have to do this. This is an order. And it was like if you've ever had a bossy older sister. And all of a sudden you had victory after a lifetime of suffering. It's the best. I still get excited thinking about it. All right, enough of that. It's an order. This is an order, and it binds everybody who follows orders. And it has three parts of it. There's an introduction, top section with information. There's a specific medical directives, and then there's a signature. Now, the provider can be a physician, MD or DO, or a physician assistant nurse practitioner, or a naturopathic doctor here in Oregon. Now, who is it intended for? Well, initially, it was intended for someone close to death. Now, how do you determine that? Well, OHSU in its wisdom said, well, let's ask the surprise question. Would your doctor be surprised if this patient was dead in a year? And if the doctor said, no, that wouldn't surprise me, they probably need a POLST. So, two things about the surprise question you'd probably want to know the answer to. So, benefits of the POLST is that you can communicate. It actually helps the DNR order, and it decreases that unnecessary sort of care. And it's sort of taken over. The whole entire country has this now. And this is the top part says, attempt CPR, do not attempt CPR, that's the DNR. The middle section says, okay, what do we do? Comfort, limited treatment, or full treatment, and you just check it. Now, which one of these sounds good? Full treatment sounds good, but what if you're kind of like me, like, oh yeah, I want to be comfortable. I like a Lexus, I like that ride. I want to be like comfort, I like comfort food. You can tell, right? Comfort measures, that sounds good. If I'm sick, keep me comfortable, doc. Don't do anything to me. Now here's a problem when you do comfort. I'm going to tell you about Walter. Walter's a patient I was called to see. I got a call from the ER one night, true story. Patient here who's got a real bad bladder infection. As a matter of fact, he's so bad, he's what we call urosepsis. He's actually dying. He's got bacteria in his bladder, causes a kidney infection, causes a bloodstream infection. He's actually dying. And he's got a pulse form, and it says comfort measures only, and I'm just calling you because he'll probably be dead by the morning. We're going to put him upstairs. We're just going to keep him comfortable. And that's kind of a call I got. And I said, oh, are you sure comfort measures are what they want? Did anybody confirm that with the family? He says, well, you know, his power of attorney lives in Arizona. And I'm like, so there's got to be someone around. So I said, just try to find, is there something, call the nursing home where he's actually assisted living, call and see if there's anybody around, get a phone number, and I'll come in and make sure. So I drove in, middle of the night, saw this patient. Sure enough, elderly man, pretty toxic. By then they had a number of a nephew, and I called up the nephew and says, you know, this is your uncle here, and he's pretty sick. And, you know, it says comfort measures on his POLST. And I just want to know, is that, you know, we're going to admit him and keep him comfortable. Are you sure that's where the family is? And the nephew goes, no, man, I was playing chess with him 2 days ago. Like, he doesn't want to just die, to be left for dead. I mean, do something. Can't you try something? I said, okay, yeah. So we basically kind of put him in the ICU for a night, gave him some medicines, simple medicines, medicine to keep his blood pressure up, an antibiotic. Within about 8 hours, 10 hours, he started to turn around. Within a couple days, he's telling me about his experiences in Patton's Third Army, okay? Chasing across Europe and blowing up all the bad guys. And then the nurse comes in, he starts flirting with the nurse. I mean, this is like your classic vet, you know, totally inappropriate. Totally inappropriate, but so hilarious that I just could not stop laughing. And he did it with a twinkle in his eye, and the nurses loved him too. So he was like, Grandpa. And he was the most interesting person I met that year, okay? The most interesting person, and 4 to 5 days later, he's leaving the hospital, and his nephew comes and says, thanks for saving my uncle's life. And I said, a medical student could have saved his life. It was just an antibiotic and a little pressure support. The hard part was reversing his POLST at 2 in the morning and yelling at the intensivist to give him a bed. I had to put all my cards on the table, everything that I had, to get that guy a day in the ICU. And that was the hard part. And I said, you got to fix his POLST. So there's problems with the POLST, okay? There's potential problems. What is the problem? It's always voluntary. You don't have to pick it up. You should only have it for people who are at the very end of life. And the problem is if you want comfort measures, that's all you get. You get a blanket, okay, to keep you comfortable. Maybe a little pain medicine, that's it. Now, if you're ready for that, at the end of life, you're on hospice, that's appropriate. POLST is appropriate for that stage. But if you're 75 and healthy, and you have some expectation of going to the hospital and getting some treatment and coming out again, don't have a POLST. You know, 75-year-old healthy person should have a POLST. Because it's just, you put comfort measures on that, you're you know, unless you're maybe one of the politicians who are running for president, maybe there's a couple of them who might need a POLST, I don't know. I'm not going to go political. Let them all have one. Next time they go to the hospital, nature will take care of business. Be okay. All right. So it's a good thing. POLST is good, but it's biased. The language itself biased towards non-treatment. It's designed for use by terminally ill people, but it's being used in healthy people. Also, when you put do not resuscitate, there's evidence that says when you have DNR on your order, you get less care. You get less stuff. And you get less surgery, you get less medicines, you get less nurse attention. And it's actually, it's dangerous to have a DNR order unless you're at that point where you really don't want it. It's powerful, like I was teasing my sister. It's an order. You can't go against an order unless you're another doctor in the middle of the night who's willing to out-yell the intensivist. Okay? And how many of you can do that? No one can. I got to tell you, none of my colleagues would. They wouldn't have bothered. So you have to have a little chutzpah, maybe, to do it, or just an ethic that all life is valuable. Maybe that's what you need. I don't know. Something like that. So the POLST can be dangerous. Comfort measures is comfort, but it's actually non-treatment. And when I see a patient who's suffering, the problem with doctors, and this is true, is when I see someone in the bed suffering, I got to tell you, I think about myself. I put myself in that situation. I'd say, man, I wouldn't want to be here. Just let me go. So my putting myself in that, I make judgments about what my values would be. And I know the nurse who's coming on the next shift, and I wouldn't want to be here for her or him. I mean, I wouldn't want to be in that bed. I know all the bad things. So if you're looking to me for a judgment about whether you want to be sick in a hospital bed, what's better or worse, don't look at me, because I'm biased. And so there's this thing called countertransference, which is I put myself in that and I use my own values to judge what this person really wants, and I'm not really listening to them, I'm putting my own values in there. And so transference is when I put, what's happening to me off to someone else. Countertransference is when I put myself in that person and put my values in for me. And so it's kind of a weird thing, but you have to understand what's going on, that physicians don't want to keep you going. They're not, they don't want to be woken up in the middle of the night. It's tough. Also, financial pressures. I actually, as a provider, get paid to fill out either an advanced directive or POLST. I get money to have something in the chart that reflects we did end-of-life discussions. Now, what's easier? I got to go through this half-hour description of this and then give it to you, and you've got to go fill it out and then get signatures and bring it back, which doesn't happen. Or I say, do you want to be kept alive or not? Do you want something to pound on your chest? No. Okay. DNR. How about if you get really sick in the hospital and there's no hope? Do you want us to keep you comfortable? Yeah. Okay, comfort measures. I signed it. It's done. That's sometimes about as much as, and sometimes it's not even the doctor who goes in. So I can get this done in that encounter. Most people have POLST on their charts. They don't even know they have it because their doctor had some kind of a discussion, which you didn't even realize, because you don't even see this form anymore. It's all done on the computer because most of this is on the electronic record. That's a true thing. True story. So take home POLST, the points on the POLST, and then we'll quit. It's a great tool. It's the best thing since sliced bread for that person who is at the end of life and you don't want to do anything more. I don't want anybody here come, they went, oh my God, POLSTs are terrible. They're not terrible. They're terrible for healthy people, but they're great for someone at the very end because comes a point in time when you don't want to do anything more. All right? So you really want to know if you have a POLST. You want to make sure that you think about that surprise question. That's who needs a POLST. Would your doctor be surprised if you'd be dead in the next 12 months? And if your doctor says, no, that wouldn't surprise me a bit. They need a POLST. So if you're in my clinic and I've got the POLST, and if I take it out and we start to fill it out, you got to say, Doc, you got to tell me what's going on. Tell me. So that's what it's for. Not everyone needs a POLST, but everyone needs an advanced directive. So what are the differences? Let's go through this. I promise we'd come back to this. So the advanced directive is for all adults, but the POLST is for people who are at the end or have serious or fatal illnesses. The health status. The advanced directive for healthy people. But the POLST is for someone who maybe they're not going to be around. It wouldn't surprise anybody if they're dead in the next 12 months. A physician, hopefully one who went to a good medical school and had a good teacher like Dr. Toffler, knew what was going on. So the focus of the advanced directive is the future. What are we going to do? But the POLST is right now. What do I do in this care right now? So it's actually an order for care that I'm doing right now. So it's a little different. Document type. So advanced directive, that's a legal document. It's legally binding, and it's something that you keep with you. And it is, but a POLST is an order. It's a medical order. It belongs in a medical chart. There's two types of document. Now, who writes it? The decision maker. With the advanced directive, it's the patient. Or it's actually the decision maker is your healthcare representative. It's appointed by the patient. The author is the patient, and the edits only the patient can change. And if you decide you want to change your advanced directive, it's kind of like a will. How do you change a will? You just make a new one with a date that's later. The most recent one counts. So it's easy to change. And you should review it periodically. Now, who's the decision maker in the POLST? The provider. Who's the author? The provider. Who edits it? The provider. Who reviews it? The provider. That's what a POLST is. And there's lots of people who kind of say, yeah, I thought I saw something pink in my chart, and I don't know what it was, but we had this sort of weird conversation, and I don't want to, you know. And so you really don't know. So it's helpful to know what it is. And again, how do you change a POLST? Is you, first of all, find out if you have a POLST. Next time when you see your doctor, find out if you have one and what it says. If it's not what you say, I'd like to redo that. Can we do that? And let me read it. And the one that I like the best, the options that we have for POLST that I like is not full treatment, but I like the limited one. The limited one, at least, you know, you're going to get, you know, say you are 90 and you don't want to be resuscitated, but you don't want to be in an ICU because you realize if you have really bad emphysema, if you get put on a ventilator, you might not come off. And it's very reasonable to choose not to be resuscitated, although you never know, and you don't really know. But a lot of my patients who have advanced illness, unless they're on hospice, I don't put comfort measures. A lot of my patients have the limited treatment, or even some people put full treatment. So that's kind of that's the danger. Like we talked about with the advanced directive, the middle section where you put all those options in that are meaningless and can be dangerous. In the POLST, it's section B that can be dangerous, especially if you put comfort measures when you're not ready to go that route yet. So that is what I have. And then we'll open it. We got about 10 minutes for Q&A. Actually, 5 minutes. I went long.
If you have a question, I can bring the mic to you.
Back.
Let's get the microphone so others can hear.
Well, usually I'm loud, so.
Not everybody.
Okay, a couple things. You talked about comfort measures. Now, my understanding, comfort measures mean if someone is in pain, they get morphine.
Pain medications, yes. So comfort measures would include all the comfort measures for comfortable, but nothing, not an antibiotic, maybe not intravenous fluids, maybe not the things that you would do for resuscitation. But definitely everything for comfort would be in comfort measures. So you get pain medicines.
Okay, second thing, can a doctor ignore a POLST form if a family member says, I want to do something?
So no, an order's pretty strong. And there's very, very hard for, and most physicians won't order, they won't go against. Once the POLST is an order is signed, that's an order and everybody follows it.
Okay.
It's a powerful document. And you only know how powerful it is when you actually try as another physician to override someone else's order. I mean, that just doesn't go over very well for anybody.
Thank you.
There's someone right
Go ahead, here.
And then, I think there was somebody up front.
Oh, go ahead. I'll let you, Doc.
How do you get rid of a POLST when they have put it into effect? When I broke my hip about a year ago, that's when they put a POLST on. I plan to live another 25 years, so how can I get rid of that?
I like that attitude. Way to go. All right. Don't start smoking. Limit your alcohol. All right. So, how do you get rid of a POLST? You can't, man. Once it's in the state registry, you cannot get rid of it. But what you can do is you can go through and say, hey, I really want, you can change what it says to something that you like. So go look at the POLST, figure out what you want, take it to your provider, say, hey, I want to make sure my POLST says this. And just update it. Hard to get rid of it.
I think you probably answered my question. I care for my brother. He take him to his doctor's appointments and everything. So how do I find out? Can I ask the doctor if he has a POLST? Because he's 52 years old, but he has mental health disabilities.
Okay, so first of all, great question. So the question is, can you find out about someone else as well? If you are a person who's signed up to be someone who can access their records and is someone who they've given permission for, you're a guardian or you're on their HIPAA waiver, yeah, you can go in with them next time and say, hey, can we look at the record? Can I look at the POLST? I'm really interested in this. I've just been reading about it. I want to make sure. Can you find that for me? And then you just go over it and review it with the provider. And their power of attorney or their healthcare representative, whoever it is. Is that you? So you're the healthcare, you're the healthcare, you can do that. You could actually do that as a healthcare representative. You could probably even call up and get that.
I have two sons, and I'd like them both to be the representative, not an alternate case? Can
Yes.
that happen?
So here she's going to make for World War III, she's actually set the stage. She has 2 sons. She wants them to be healthcare representatives. I got to tell you, you know, that's what a lot of people say. And they say, I can't make a decision. You got to make a decision. You have to have one person who's in charge. And if they're not available, the second, because how does it work when you got 2 people who disagree? Who does it? You have to have one person, and that's what it is. And if they're not available, the next. Yeah, it doesn't work to have a team with this, because you got to pick one. I'm sorry. You got to do it. That's hardcore, I know. So, and don't pick the one who would do what you would do. Pick the one who has your value, who has your heart, who would do exactly, would be as if you were doing it. Who would reflect you the best, and that's who you go with.
Yeah, Dr. Bentz, a number of years ago, a very young doctor had me make out a POLST, and which I don't need, you know, that's a number of years ago. So I called up OHSU and had, you know, I just ripped it up myself, my copy, and then I called up OHSU and had them destroy it. They said they would do that.
So the POLST registry?
Yeah.
Or the hospital?
Well, OHSU POLST registry.
Okay, so maybe they can do it. I don't know. Once something's online and once something's electronic, how does it really, is it really deleted? I don't know. So but here you have someone who says, for the first question, can you destroy one? Evidently, yes. And I believe you because I trust you. But I don't know if I trust OHSU. I don't. I'm sorry.
Yeah, you talked about the lady that took care of that old guy that had nobody with him. Is there really a big opening for ministry of people in nursing homes? How many are out there that really need an advocate?
So this is something that I love that question because it's on my heart. And I take care of so many people who have nobody. And I don't know if there's a ministry that's established, but there's one waiting to be formed. And
There is something called nursing home ministries. There's some chaplains that are associated with that go around and they will minister to people in nursing homes.
Minister
to the
is different than being an advocate. There's ministry and then there's being being a healthcare representative for someone and being their partner to go the last bit of the journey with them.
That might be a role that some of us might want to consider.
If someone here could come up with a great name and a chapter and a set of bylaws and what we do and what we don't do, I got to tell you, Oregon Right to Life would get behind it 100% because it's just like having a home for unwed mothers. If you're there supporting these older folks who are despondent and in despair and lonely, here's the thing, if you got someone who loves you, who's with you, and there's warmth and tenderness, you don't want to leave. That's a good place to be. If you're alone and afraid, death is better. So suicidality would go away if we could do that. So I got to tell you, I'm thinking it's good. And we have about 4 minutes to get to the plenary.
We have 2 questions.
We got 4 minutes to get to the plenary.
Okay.
It starts at 4.
It starts at 4, right? 4:10. Okay, we don't.
When I talked to my doctor about the advanced directive and the POLST, she highly recommended the POLST. And her reason was, she said, say you passed out in your home, you were on the kitchen floor and you weren't breathing. She said a POLST means that they would do something for you. An advanced directive doesn't. Can you explain that?
So, very good. So, and again, I was part of that. So the question is some doctors are recommending the POLST because it's like if you go down, this POLST gives people direction. Well, here's the thing. If there's no POLST there, the default is they do everything.
Anyhow.
So they do everything. And if the only time they limit care is with the POLST is for limiting care, not for giving care. Now, the advanced directive, everybody needs an advanced directive because I want to know if you get into a spot where you can no longer speak for yourself or think for yourself, who speaks for you or thinks for you? Everybody needs that healthcare representative, so everybody does. And the problem is there's nothing for advanced planning on the POLST. There's no place for your healthcare. So everybody needs an advanced directive. And when you get older and frail and life is short and you don't want to be resuscitated, then it's time for the POLST. And you look like you're going to be around for a little long. I probably wouldn't pull one out for you.
You know, the pro-lifers say every child should be a wanted child. Well, I think the new euphemisms is that every granny should be a wanted granny.
I agree. I'm in. That's great.
Now, is there good hospice and not good hospice?
So I could talk about hospice, but I won't. I'll leave it at that. We can talk later. I'll tell you why.
2 questions.
That's not me. I'm still out.
I appreciate your talking about someone coming along and being a friend to the elderly. I'm one of the elderly. We've had some bad experiences with people that come, want to be friends with the elderly with very, very bad motives. So be aware.
I totally agree with that. That's really true. Be careful. That's why we need someone like this guy over here to run a good one.
I live at an independent living situation. It's a continuous care retirement community in Salem. And they tell us to fill out these posts and put them at our door. So if their family's not there, they call the ambulance, and the ambulance can take care of that. But I've found that the ambulance can't find it usually, and there's nobody there to help.
Yeah.
And they just take them to the hospital. I've gone to the hospital with some of the people.
Yeah, so that's why it's pink. That's why it's that hideous color pink, because there's nothing else in your whole house or room or world that has that color, so that the paramedics are supposed to have this ability to see this pink. In Washington, it's even worse. It's this lime sort of fluorescent green.
Yeah.
It's even worse.
Hey.
So there, go ahead.
One more question.
Let's do it.
Then I think.
Actually, it's more of an offer. If you were in my workshop, you heard me mention I started something called Decision Care Advocates to fill the need that you are expressing.
There you go.
And I'll stand at the back if anybody wants to talk to me,
Way to
if
go.
it's a start to help.
Someone's already started. Look at that. Amazing. Thank you. So, very good. I'm going to finish with this very last slide. So, the very last thing, it's never a burden to give someone a roof over their head, a warm, clean bed, and most of the time, something to eat. Everything else is a judgment call. And you just use the tools available to protect your loved ones, protect yourself. We got good tools. They can be misused. Don't be afraid to speak out for your loved one. And I heard someone say, Mama Bear. That's like a real, you know what Mama Bear does? There's this movie called The Revenant. You don't want to see it. It's pretty gross. It's awesome though, man. This bear just mauls this dude. Leonardo DiCaprio gets mauled. It's the most awesome scene of a bear almost eating somebody. It's well done. Don't be afraid to be that bear. If any ambiguity, err on the side of life. Thanks.